All right, guys. So welcome. My name is Shanda. I'm actually the nurse educator here, so it's really good to have you guys here. I know you've got your schedules now, and we'll talk offline, but we'll figure out your TB test if you don't have one. And I know some of you did Relias, so I know you did the infection control part, I believe, right? So a little bit additional hands-on with that is at the end we can do it. You've already done it. I watch you wash your hands. We talk about putting on PPE and taking it off, so I can do a checklist with you. So we'll do that at the end. But she's already done that, and we'll catch you up. So first thing we're going to talk about is dementia. I know this is kind of new for you as far as the medical field, correct? So have you guys dealt with dementia patients at all? A little bit. So you know there's some challenges there. So we like to talk about it. One, to understand what's going on medically a little bit, and then two, some techniques of how we can help them, okay? So first and foremost, just understanding what dementia is. Dementia is classified, this is the official, description, but significant deterioration in two or more areas of cognitive function that is severe enough to interfere with a person's ability to perform everyday activities. So it's not a quick diagnosis, and it's usually a little bit of a time frame and family talking and saying, we're noticing some differences. There's different stages. The early stage very commonly will try to hide that they're having some deficits, because as a human we don't want to deal with that, right? So we'll kind of, oh no, I just forgot. You'll see that. Typically in that first stage you're not going to see them here necessarily. Maybe assisted living, but to be in the skilled they're usually a little more into the stages, okay? So an overview, dementia is a general term that kind of covers a variety of neurodegenerative diseases. There is different kinds. Most of them are untreatable. There is one kind that can be treatable if it's caused by like medications or something like that. It's chronic, persistent. There is no cure, like I said. It will progressively cause damage to the brain cells. In a little bit, I'm going to show you, it's a really good video that just quickly describes, and I'm like, wow, even as a nurse, that really simplified it for me. There's, like I said, different types, and the symptoms are going to vary depending on that type. For example, Lewy body is very, very young, very quick, and it's really devastating. We actually will not typically take a Lewy bodies because it needs more acute care. Dementia is not part of the normal aging process. Just because I'm getting older does not mean I'm going to lose my memory necessarily, so don't assume that, okay? And some symptoms of dementia are potentially caused by treatable diseases. They could have like a meningitis type thing going on, and it could present almost like a dementia, for example, or they could have had a vascular dementia. So there's different kinds, and we'll get into them a little bit. So, like I said, it's irreversible, it's progressive. These are kind of the different kinds. You've got your Alzheimer's disease, which is about 80% of your dementia, and that's what's most common, and what the world is most familiar with, if you will. Multi-infarct dementia or vascular dementia, Creutzfeldt-Jakob disease. I'm not even that familiar with that. I have not seen that in my career. Dementia with Lewy bodies, and frontotemporal degeneration and Parkinson's related. So they could have Parkinson's with the Alzheimer's. So here, I'm going to show you this video. I just think it's a really good one that breaks it down for you. Bear with me because I got to do technical stuff. And it's saying I can't do it. I remember last time, it's kind of funky. I had to undo this. It's still, I've never had that before. I don't know, it's never done it before. Sorry guys, hold on.
Of course, right when you need it.
Always. And it's such a good video, I really want you to see it. It's like a 2-minute video, and I'm like, wow, that really explains it. never had to do this.
The browser is up to date.
Maybe. Oh, maybe because I'm in presentation mode. This thing is so fickle when it comes to this part. Most of the time I try not to put videos in my PowerPoint because of this. Think we're working. Media. Pause. Yay, it's so happy. Oh, there he is. I see him. I was like, where is the mouse? Lordy.
Slow, fatal disease of the brain, affecting 1 in 10 people over the age of 65. No one is immune. The disease comes on gradually as 2 abnormal protein fragments, called plaques and tangles, accumulate in the brain and kill brain cells. They start here in the hippocampus, the part of the brain where memories are first formed. Over many years' time, the plaques and tangles slowly destroy the hippocampus, and it becomes harder and harder to form new memories. Simple recollections from a few hours or days ago that the rest of us might take for granted are just not there. After that, more plaques and tangles spread into different regions of the brain, killing cells and compromising function wherever they go. This spreading around is what causes the different stages of Alzheimer's. From the hippocampus, the disease spreads here to the region of the brain where language is processed. When that happens, it gets tougher and tougher to find the right word. Next, the disease creeps toward the front of the brain, where logical thought takes place. Very gradually, a person begins to lose the ability to solve problems, grasp concepts, and make plans. Next, the plaques and tangles invade the part of the brain where emotions are regulated. When this happens, the patient gradually loses control over moods and feelings. After that, the disease moves to where the brain makes sense of things it sees, hears, and smells. In this stage, Alzheimer's wreaks havoc on a person's senses and can spark hallucinations. Eventually, the plaques and tangles erase a person's oldest and most precious memories, which are stored here in the back of the brain. Near the end, the disease compromises a person's balance and coordination. And in the very last stage, it destroys the part of the brain that regulates breathing and the heart. The progression from mild forgetting to death is slow and steady, and takes place over an average of 8 to 10 years. It is relentless and, for now, incurable. Helping your family, friends, and neighbors to better understand Alzheimer's will reduce stigma, improve care, and even help the fight for a cure. Thanks for helping to do your part.
So, at the end of the day, this is a,
At www.
it takes your life, and I don't think people realize that part. So, I just like that video because it really kind of just breaks it down real quick. You guys have any questions or comments after that? I mean, I just think that's really a good way to do it. Okay, now, repeat again. This is the only downside to this room.
Many people, as they get older, may notice changes in memory and thinking abilities. At first, these changes may be so subtle that they're easy to explain away as normal aging. And they may be. However, it's also possible that they're the earliest symptoms of Alzheimer's disease.
Bear with me. Get rid of that. Okay. I don't do the other video. I just think that one covers it pretty well. We're back? Okay, cool. Here we go. So behaviors. So now that we understand a little bit about why these things are happening, some of the things you're going to see with the behaviors is, they have cognitive and functional impairments. They could have any neuropsychiatric behavioral consequences. So just like it said, you can see hallucinations. They get mood disorders because it's affecting parts of the brain that actually affect the way they have moods. So that's why you'll see sometimes somebody just crying, they can't control it necessarily. Sleep disorders, we all probably know that, even if you're not in the medical field, because you've heard of probably sundowners, or they're up in the middle of the night, that's when they wander the most, so that comes with that. Psychotic symptoms, like I said, delusions, hallucinations, and of course agitation. Exit seeking, which means they're trying to get out of the building or get out of the where we are. Sexual disinhibition. You will see people that have been humble their whole life, all of a sudden taking their clothes. It's not their normal behavior. So what that really means for us is dignity. They don't want to be seen like that. And even though mentally they can't help it, we do our best to keep their dignity, keep their privacy, and keep that intact, okay? Anxiety, they get combative. We do not see a ton of that here. I'm not going to say you're never going to see that, but just what we want to do is prevent that the best that we can. And I really, truly believe we do a really good job here from anywhere I've been. And then that's just the truth from my soul. Causes of behavior, which we kind of already went over, but behavior is a means of them communicating. When they have dementia, they can't communicate correctly. So they may have some unmet need, but they don't know how to tell you that, okay? So now they're agitated, or they're exit seeking, or anything like that. Or calling 911 because they have to have a bowel movement and we didn't get there quick enough, for example. So let's talk about that for a minute. We want to prevent that, so we are going to learn our residents a little bit and prevent those triggers. For example, there's one resident, I will never get a baby doll again, right? She got it, she did well, but then all of a sudden it was almost traumatic for her at the end. So we're just like, never again with that. And we care plan these things, we do trials. It's not like we just willy-nilly do things, we do it with purpose. So some of the triggers, noise. I have one resident, he is in his room, he doesn't like the noise. And here he goes, loneliness. I had one that used to she just missed her family and she'd roll down crying and it'd break your heart, and there's nothing you really could do other than just console her, be there, maybe distract her, okay? Boredom. We have a very nice activities department here. I believe they do a fantastic job, but you can tell when they're not here, if that makes sense. If they get bored, they start wandering and they're getting confused. If you keep them kind of involved, and it helps not only keep their memory a little bit, but kind of keeps them from getting bored. Some don't want to come do those activities. We encourage it, but we'll never force them. Maybe we'll meet them where they are. Maybe they like to be in their room and listen to music, and that's their activity, and they do that. Hunger, thirst, that's a big one. As we age in general, our thirst mechanism, that thing that says, hey, you're thirsty, drink, it already decreases. Now you add dementia on top and those inability to communicate or think about those things. That's why we make sure that they're drinking. That is huge for us, especially at your level. Nurses are counting on that you're doing those water passes and things. Things like that seem small are pretty big, okay? Hunger, thirst, elimination needs. I have, how many do you think? 3-4 people that are behavioral around bowel movements. You can tell when that's a problem. We do monitor it. As people on the floor, if you're seeing things, come tell us. We want to know as nurses so that we can get on top of that. And maybe they're just scared and confused. They woke up and they don't know where they are all of a sudden. Maybe they have a lucid moment. Think about that. That's pretty scary. And they get frustrated. They cannot speak sometimes, and they're just, they want to tell you what they need. It reminds me of expressive aphasia I see in strokes where they're mentally there, the words are there, but they can't get them out. Imagine how frustrating that is. So these people are going through that. So what do we do? Interventions, talk to them one-on-one. You will see housekeepers stop and talk and console a resident. No problem. We love it and I encourage it all day. It's a whole team effort. Redirect, maybe one of my little friends is way at the end of the hall. Maybe I redirect her. Let's go down here. I think they're playing bingo, right? We're keeping them safe. Offer food and drink. You hungry? I don't care if it's mealtime. I mean, do you eat at specific times every day? I don't. So maybe they're hungry. Like I have one that kind of will be up a few days, sleep a few days, and if she wakes up at 3 a.m., she wants coffee. So we'll give her coffee. We actually know it. We already have it ready. Offer the toilet. Maybe they don't realize that's what they need. Oh yeah, that is. Or maybe you just get them in there and then they change their behavior. Another thing we do is try to get on top of those. We do like bathroom checks and things for certain people, bowel programs, things like that to kind of prevent that. Maybe I go get Vaughn because she knows this resident really well and she's acting up, but when Vaughn goes and sees her, it works well. That's okay, we're a team. You know what I mean? I have one resident that calls out for specific team members all day long because she really likes them. The other thing is PRN pain meds or anti-anxiety meds. Now, obviously you're not passing meds at that level, but you could let us nurses know if you're seeing, oh man, I know when this one yells out like this, that means there's some pain. I'm going to go tell her because we do want to hear that and we listen. Communication. I'm not going to go every word for word, but just you're going to meet them where they're at. A lot of times I like to get down to their level because it's less intimidating and it's more personal. And I'm one-on-one. I'm not, oh yeah. Oh, what were you? Well, yeah. Pay attention to what they're saying, please. That's what we want you to do. Short phrases, words, you can't talk like I'm talking to you. They just get really confused at certain levels. So you want to give one direction at a time. Put your leg in the pant. Nope, put your leg in the pant. Okay, now we're going to put the other one. And I'm sure you've been taught that, but that is huge. Especially as they're getting a little more frustrated, just slow down with them, okay? Be patient, gentle, even if you're being firm. Give a resident time to process what you said. That's another thing. Sometimes they just need a minute. And you've probably seen this if you've dealt with anybody in the geriatric population is, hey, how was lunch? And they're trying to get it out. Don't speak for them. Give them a minute. Or sometimes I say, it's okay, take your time. Some we do communication boards. We're really good at just patient-centered or resident-centered. It's about what they need. And just make sure you get to those interventions, again, preventative maintenance, okay? So just a few facts. These are outdated. I do have to get them updated, but they're pretty close. So Alzheimer's disease, most common type of dementia in people over 65. Like I said, it's really closer to that 80% right now from the last statistics I'm seeing. So Alzheimer's is about 80% of those dementia cases. And right now it's actually up to about 6.2 million Americans. In 2050, the number is expected to be more than double than it was due to the aging of the population. We've got the baby boomer generation. I'm sure you've heard that. And it affects a lot of people, basically. So, again, I'm not going to read this word for word, but keep in mind, just because that someone is a geriatric does not mean they've lost their memory, doesn't mean they're hard of hearing, doesn't mean they can't see. I've got a 105-year-old that could probably outrun you right now in her little wheelchair. So, don't assume. Get to know them, ask questions. They have care plans. We want to know our residents, and we're very close here with them, okay? Some things to avoid, these questions about time, place, people. What did you have for lunch? Ooh, that could really set someone off as they're trying to think, they can't figure it out, it gets frustrating. So I'll ask questions more like, did you have a good lunch? They might not even remember they just had lunch, but they're not going to get frustrated and they could say, oh yeah, I did, or I think so. What time did your daughter call? Please don't ask that, especially with a dementia patient, because they still will know, like, hey, my daughter's calling. There might be a day off, but don't initiate that. Be very careful with that question. Who was sitting with you today? Those recall of memory questions, don't ask them. That's painful for them, okay? And that can cause agitation. So, just a brief overview. How do we take care of dementia patients successfully? We get to know our residents. We understand the disease process, and we meet them where they're at. Stop and put that relationship with them before the task. Yes, the tasks have to get done. We are very task-oriented in the medical field. The briefs have to be changed. Everybody's got to get down to lunch. But if somebody needs your one-on-one, count on your team. you know, you may have to tag us in because you gotta go do those tasks, but like, talk about it, don't just rush, we're here for them, okay? Don't be afraid to be silly. We, just on Valentine's Day, we were singing all down the halls, we took our residents to a concert and they loved it, and we had fun, so it's okay to have fun here, even though I'll jokingly say, no fun at work. I know that my way is not always the way, and you're gonna listen, watch what other people do. You know, especially people that are seasoned, because they know these residents. They know their family. They know their family's family. They know their family's friends. So that is it on dementia. Just a big part of the takeaway is that effective communication. I've said it a million times, that preventative maintenance. I don't have a quiz on this, but do you guys have questions, comments, concerns? Okay. I do have technically we have 2 dementia units. One is not open right now on our skilled side, so our dementia, they're just kind of mixed in the population right now, and that has to do with COVID, but hopefully we'll get back up to full staff, and we'd love to open that unit. And then I do have one on the assisted living side. I jokingly say every time, I've only peeked in the window about 3 times, and every time I do, everybody's chill. Everybody's just hanging out, having a good time, so it's nice to see. That's a difficult population.
Would the same people be working in the dementia unit? Like, would that be your unit?
People will get to their niche. I'm not gonna say that we only staff here and there, but if you're somebody, honestly, dementia is one of those, if you prefer it, that's who I want there, because
Yeah.
I'm not technically a dementia person. It's not my favorite thing. I'm getting to a point where I'm liking it more and more, but I think it's because I'm learning more and more.
Mhm.
But if you're like, man, it's just not for me, we're not gonna think you're a bad person. I'd rather you be honest about it. Like, you know, I tried it, it's just not me, or maybe I want a little more training. Any of that, come let us know. We are very open to that. We want to grow our own. We want to build a really good cohesive team. So if you have questions, comments, please let us know. We'd love to get you whatever you need, okay?
Yeah, there is times that you might end up working in the unit.
Right.
It depends
If
on
we
staff,
need it,
but
yeah.
we usually have certain people that prefers the unit and of
Yep.
course that like and know how to handle the dementia
Right.
patients.
My recommendation is, whether you like it or not, get in there, get a day of training if you
Yeah.
can. That way,
Mhm.
if that's the case, you don't feel so uncomfortable.
Yeah.
Okay? So folders, I'll have you guys, there's a couple different things in there, and I know you started yours, so now there's some more. The next thing you're gonna see, it's called the CINA RAMT Standards of Care Guidelines. It's after the infection control. I'm sorry, that's for people. I lied. You got the hand washing stuff. When you get to the CINA, just pull these out for now because we'll do these later.
Which one was it?
So it's this one. So once you get to that point, that's where I want you at. Am I good? I tried to keep them in order, but it's like, depending on what day you do or if you do relies, it kind of messes them up. So the CNA RAMT guides, I am not going to sit and read these word for word, but the essential, what we're getting at is that you guys are coming here to take care of these residents. I tell them all the time, I get paid to take care of you. That's literally my job. So I don't mind if I need to spend 20 minutes, you know, because you're crying and you're upset. That's fine. That's okay. That's what we're here for, right? So these CNA standards, again, I'm trying to build a really strong, cohesive team. St. Anne's is an amazing place to work. And I'm not just saying that. Like, I really love it here. So what I want is team members that are ready to come to work, ready to take care of these residents. Yes, it's hard sometimes, but you're gonna get the vitals. You're gonna make sure they're drinking. You're gonna make sure you're following the rules, because the rules are there to keep them safe and us safe. Things like not eating in the dining room when they're eating, that's an infection control thing, and it's a presentation thing. So you're gonna come, you're gonna have your equipment, you're gonna be on time, you're gonna, you know, that way your other team members are gonna do the same and you can get out on time, because that's civility, you know, we don't wanna be incivil. So if you guys wanna read through it, you can, but at the end of the day, we do have to get you to sign, and then we can make a pile of, and I have some papers, including this, that you guys are gonna give me. Any questions on this? So, and then at the bottom, it's just telling you, like I said, it comes down to, you're gonna brush your teeth when you're doing oral care. You're not gonna say you did it and not do it. That's not how we do here. Okay?
Do you require us to bring our own gate belts?
We are gonna get to that next,
Okay.
and actually, I'm either going to give you one if you want, or if you have your own, you can say, no, I'll wait, but we do offer one free one at any time.
Okay.
So, like, let's say a year from now, you're like, okay, I finally am ready, we'll get you one.
Okay, cool.
So that's actually the next thing we're gonna talk about is like ADL, Hoyer lifts, Sarah lifts. Anybody familiar with either of those?
Mhm.
Yes, all of you, okay. So that's what we use on the skilled side. On the assisted living side, technically we don't use lifts, but that doesn't mean if there's a fall, you can't, right? Geez, correct me if I'm wrong. If they have a fall, we can use a Hoyer to go help in assisted living.
yeah.
Bear with me a second. It's something about when I have it connected, it just doesn't like that. There we go. You guys do have this PowerPoint in there if you want to take notes or follow along on paper. It looks like this. If you want. Definitely don't have to. Well, it helps if I look at this. It's giving me problems. Okay. So ADL levels of assist in lifts. Some of this is more just so we're all speaking the same language when we say some of these things like independent versus moderately independent. You know, we have to do things within a certain framework that is regulatory. So we want to make sure we're all speaking the same and understanding. So manual transfers, so different levels of assist that you would be charting. Independent resident does not require physical safety. That means like you don't really have to do nothing, right? That's the easiest one to understand. Moderate independent, maybe they're walking with a cane or walker, but they're doing it themselves. They got this, right? We're just kind of right there. Supervision or standby assist. They do not require any hands-on, but you may have to be there and be like, okay, yep, we're done brushing our teeth. It's time to get in bed, okay? Use your eyes, mouth, no hands. Limited assistance. Resident does not require physical assistance, but they might, you know, like I just about dipped there, you might have grabbed me, okay? So that would be like a limited assist. Residents highly involved in activities. Staff uses hand to guide, but not bearing any weight. The term staff hands on top. So then we get into the extensive assist. Resident requires physical assistance from one individual to complete a transfer safely. Use your hands and muscles, bearing some or any weight, so they might just kind of lean into you. Staff lifted a part of the body, hand, like maybe you gotta help get their leg in the bed. Or staff hand underneath is another kind of way to think about that. Extensive assist times 2, resident requires physical assistance from 2 individuals to complete a transfer safely. So maybe we do have rehab. So maybe we're going from the lift or the Sarah lift to try, you know, therapy. We'll say we're gonna do the 2. I want you guys to be very careful at that point. Those are the most critical patients that when we're going from that to that you really need to be very careful because that is a new thing for them and they're building strength from whatever process they're going through. So be very careful. Dependent, we're doing a lot. We're doing it all, okay? So weight bearing restrictions, again, if you're on my skilled side, we do have short-term rehab patients. So you may see some of this. Non-weight bearing, I had a knee surgery and I cannot put any weight on that leg, right? Toe touch weight bearing, so maybe I can do this, but I'm not putting a lot of weight. It's just a real quick toe touch. Weight bearing is tolerated. Okay, I do good, but oh, and now I'm done, right? Or I can do this, but I can't do this, so to speak. But they can start putting some weight. And of course, full weight bearing, they're doing it. They're on their own. We like to see that, right? Maxi move, you guys are familiar, so let me just read through real quick. This can be used for all residents. If a resident has a sudden decline in condition and staff does not feel comfortable transferring with 2 assists, may use the Maxi move. Designed for one caregiver to use, but sometimes we care plan and 2 follow that care plan. That is your protection and that is their protection, okay? I know we're in a hurry, I know we're do it right, okay? Please remember to change batteries. We do rotate our batteries and there's a whole system. I'm not gonna get into it because that might be overwhelming. When you get on the floor, they will show you. That is important in our battery life. So, you know, it doesn't seem important, but we need these lifts working, right? We don't wanna have to share one, trust me. Maxi move is used for lifting, transferring totally dependent individuals. It's safe up to 500 pounds. Able to lift resident patient from the floor, bed, chair, toilet, don't matter. We have all kinds of chairs. We have shower chairs. We have bariatric chairs. We have what you need. If you're going to use it with a scale, just make sure you're not leaning on it. And I don't think we do that at all, do we? I don't think we do. MaxiMove comes with a selection of standard slings. So our residents are sized for their slings. We monitor that very frequently. We just did an audit, I believe, of a lot of this. On their boards, it will tell you what their sling is, how they're supposed to move. We are very diligent at keeping those up. You could almost 99.9% guarantee they are accurate to the minute. Inaccurate? I mean, okay, within the hour.
Yeah.
And my other thing I want to say is if you know it's wrong, question that, because maybe we did forget to throw it on the board, and I'd rather get it on there than you not say something because you don't want to tell the boss that she didn't put it on there. No, tell us, okay? It'll also be in their care plans. If you guys feel like a change needs to be made, you cannot make that change yourself, but you can come to nursing. We can upgrade them. Let's say they're on a Sarah sling and it's midnight and you guys are like, something's not right. Maybe they're having a change of condition. You go to the nurse. As a nurse, we can say, let's do a Hoyer lift and we can get therapy involved. We cannot downgrade. Not me, not you, not anyone. It's only therapy. So meaning we cannot take them from the Hoyer down to the Sarah. We can let them know we think they need that, and they will definitely check into that if it's appropriate, okay? But there is a different slings. Most residents, I think this is really cool, they mostly have them. So it's not like you're constantly going, I gotta put one on. No, they have them on them. Like they have their own
And they
for the
keep
most
them
part.
in their room.
For the most part.
Okay.
Can't promise all the time, but if you don't have one, I'll show you where we have more. And there is specialty slings if needed. I'm not gonna do the video because you guys are all familiar with it, but it's just showing you how to use it. When you get on the floor, I want you to make sure at least one time somebody really shows you. If it's not me or your trainee, you can grab any of the leadership. Or even Jackie, she's about to have a baby, but Jackie's our restorative aide, and this is definitely her home turf. She actually used to teach this, so you have a lot of resources. If anything breaks, please don't just say not working on the machine and then go about it. Please email, I'm the person, let me know when I'm off, probably Vaughn, okay? But you gotta let me know right away so I can get you what you need. My job is to make sure you have what you need so you can take care of my friends out there, okay? So if you got a broken machine, let us know. Sling's broken, let us know, okay? Sarah Lift, standing rehab aid for extensive assistive individual. Resident patient needs to demonstrate some weight bearing ability. It's very unsafe if they can't hold any weight. They're gonna fall and somebody's gonna get hurt. It can be used to stand the resident up, patient, resident, just telling you can toilet, bathing, all of that. Excellent in aid, even in dressing and undressing for toileting of the resident. Optional with Sarah is a commode attachment. I don't think we have that, do we? I don't think so. So, anyway, just so you know, it's out there. Sarah Lift, resident must be evaluated by therapy before they can use it. 1 to 2 staff assist, you go by the care plan. Or you up it if it's a safety issue. I'd rather you add than ever take away. Don't ever take away. You know what I mean by that, okay. Resident must be able to follow directions to hold the handles. If resident lets go during a transfer, notify a nurse and let therapy. I mean, if they drop, you can redirect them, but if they're not able to hold on, that's a problem. However, they can. One-handed is okay. If they have a stroke, as long as they can do it, that's still appropriate if they're care planned for it. Gait belt, as you asked, it is a part of your uniform. It should be on you at all times. With that said, most have them in their room as well, but that doesn't mean you shouldn't have it. There's no excuse. I have thousands of them. We can get them for you. Like I said, you get one free. After that, it's like $10 and it can be payroll deduct. So don't ever think you can't get a gait belt. We want to have those. Gait belts, you put them around transfers for residents. They can do a lot more, but they just still need that little bit. It keeps them safe. You want to make sure it's around the right part. It's, like I said, part of your uniform. When not in use, gait belts are not to be carried over your shoulder. It's an infection control thing. I know a lot of people just kind of put them on. We can issue one, like I said, additional gait belts can be obtained. I told you all of that. That is the end of the slideshow. So actually your next thing should be the gait belt. Should be a little form. Did I get you out of order? Oh, you got here too. That's a little confusing, ain't it? That's all right. We'll get you through. It's probably right behind that PowerPoint. Here it is. So, who wants one? Who doesn't?
I want one.
One.
I have one.
So you can opt to say, I have one, I don't
Okay.
need one at this time, but that doesn't mean you can't come back and get one.
I might.
Fair enough.
Sure, I'll lose.
Remind me, skilled side or assisted living? Your assisted living, your skilled? You're both assisted. It just depends on which bucket I take it from. So I will get those. Andy's probably gone for the day, but I'm gonna make sure that Stephanie knows you need them. Just writing a note. So with that, sign the appropriate part that works for you. If you're getting one, mark that, and if you're not, there's another section. You guys see what I mean?
Mm-hmm.
Okay. I got my note. The next two things are actually the Maximove Sarah Lift quiz, so let's go over those. Which one do you guys have first, Maxie? Alright. So I like to talk through these as a quiz because it gives us more information that make sure we hit everything. But let's go through them, and I'm gonna let you guys kind of answer first, and then we'll see what we need to discuss. I'll let you get your names on there. It's a lot of papers, isn't it? I know. And if you know answers, you're more than welcome, go ahead, but I'm just gonna start talking through. So what is the safe working load for the Maximove? You guys remember? Or the Hoyer lift? Yep, 500, correct. The Maximove is a mobile passive lift with a removable interchangeable spreader bar. Is that true? True. Maximove handles tasks such as lifting, transfers, repositioning, toileting, ambulation, and fall recovery. That's a big one. Just remember that even if somebody's not on a Maxi, if they fall and we need to get them up and they're a little shaky or whatever's going on, we can grab that, and I would prefer you grab that, and the nurse probably will tell you to grab that. So, DPS or dynamic positioning system enables the caregiver flexibility to set the resident upright for exact positioning in a chair or reclining for a placement on a stretcher, bed, diagnostic table. True or false?
True.
True. So I'm gonna stop there and just make sure, one thing we noted, when you have someone that's like laying flat and you're getting ready to get them in the wheelchair, please do not do this. That is very scary.
Mm-hmm.
They should be like this, then, right? Okay, make sure I'm saying it right. Because, and I keep telling people, if I see you doing it, I'm gonna put you in the air like that and let you feel it, because it's scary. So don't do that. The transferring of residents should never be done with the chassis legs closed. What do you guys think? It's actually false. They can be. If the spreader bar is lowered on the resident, the unit's anti-crush system will prevent further downward movement of the spreader bar. Does that make sense what it's saying?
Mm-hmm.
It's very true, so it'll stop, so you're not like, oh, hey girl, what are you doing this week? And when you're squishing no, that's not gonna happen, but you should be watching them, please. Place the sling around the resident so that the base of his or her spine is covered and the head support is behind the head. It's true, yep. And the other thing too is we do have the spine stabilizers. They're a little plastic piece, so once you're getting ready, you got them on, their sling, you're gonna stick that in before you move them, and then when you're done, you take it out and put it back. They're on the machine. There's a ton in this extra closet that'll show you where the slings are, but that is proper way to use it, so make sure you're doing that. Last one, before transferring, position resident to face the caregiver at the highest height possible. False. All right. Everybody passed. Go ahead and sign, and then we can put that in your pile. All right, same thing. Let's go over the Sarah lift real quick. I didn't tell you this, but what is the safe working load of the Sarah 3000? It's actually 440 pounds. Does Sarah stand for standing and rising aid? It's true. Yep. Before the Sarah 3000 can be used, a full clinical assessment of the resident's suitability and condition must be conducted. True. Residents who can only hold on with one hand, such as those who have suffered a stroke, cannot be lifted with this. True. That's false. As long as they can do it. A second caregiver may be needed to support the patient while the sling is being removed. If the resident lacks sitting balance and has been returned to sit on the side of the bed. True. Regular battery recharging process will prolong their lifespan. True. And those things are not cheap, so I really appreciate if we can do that. Keeps you with multiple lifts. An assessment must be made as to whether the resident requires the lower leg straps. You guys are familiar with the ones, like once you get them on, it kind of just velcros behind.
Like around their calf, kind of.
Everybody better have those on.
Okay.
Every time. Okay, so that's actually false. It's not an assessment, it just happens. Do not touch or lean on a resident if you're on the scale with it, which we never do, but of course that's false. Or true, I mean, that you wouldn't do it. The safety feature of emergency lowering allows for the resident's own weight to slowly lower the lift support arms. So I'm up here, I'm doing my thing, and all of a sudden my battery dies.
Oh, a little-
It's gonna slowly use their weight, so that's true. Safety mechanism. The Sierra 3000 slings comes in a variety of sizes and materials. True. That's it. Sign that one for me.
So I know you said the Maxi,
Excuse me.
the Maxi Move, they get their own slings. Is that kind of the same with the Sarah
All of
Lift?
them.
Okay.
All of them, yep. That's why I really want us to take care of the equipment, because we're very fortunate, I feel, here that everybody kind of has that. In places I work, that's not been the case, so I'd like to keep it that way. So if we can take really good care of our equipment, we'll continue to have better.
Franks.
Oh yeah, we're not doing all that. So the next sheet you have should be a checklist for perineal care. I'm not necessarily checking you off. I like to just talk through this, make sure you guys are confident as far as you can be before you do hands-on. If you've done it before, you're probably confident, and you've done it in clinicals, I am sure. So I just want to read through. Obviously, first and foremost, please, their privacy. Again, we're task-oriented, and I'm guilty. I stop and like, wait, let me shut this curtain. Even if that door is closed, because we're popping in and out, just think of their privacy. You wouldn't want to be laying all out, right? Make sure you got everything you need. Knock and gain permission. Make sure you explain to them what you're doing. Even if they don't understand, please explain to them who you are and what you're about to do. That could be traumatic. Make sure you get all your supplies. Basically, you're going to be doing this a lot when you do your bath shower days. It's important, and especially if they have a Foley catheter, which I don't think we have anybody here right now in the whole building that does, but if they do, you really need to get into that meatus, make sure that you're getting that clean. That will prevent UTIs, and UTIs are very deadly to this population, and they're very common. So this is how we prevent that, is good peri-care. And if they're using the bathroom and there's someone that needs a little assistance, take that time and make sure we're getting them clean. Especially if, like, think about somebody sitting in a wheelchair all day, and then you know that's painful, so we want to make sure they're good and clean. I'm not going to go step by step because it's kind of redundant, but just say and make sure that after you're done that you clean up and that you make sure they have that call light next to them, okay? Any questions on this? If there becomes a Foley and you're uncomfortable, again, Shanda, I've never done one, maybe show me, or it's been a while, please, I don't mind, or Vaughn, any of us, we don't mind. We'd rather get you right, get you trained so you know you're doing it right. Any questions on perineal care? Yes, we expect it to be done when it's appropriate. If you don't mind signing the bottom of that one, I just check it off later that we verbally went over it. I kind of like having you here just in case there's little pieces I don't know. I didn't introduce you, I'm so sorry.
Oh, it's fine.
This is Vaughn, she's our ADON. Is it official?
No, not
Okay, unofficially, hoping soon, ADON, or Assistant Director of Nursing. She's also, and she's a fabulous nurse. This woman really knows a lot, and she's a good resource. She's gonna be a little busy for a minute, but she's there. We're in the floor, we're in the mix, you'll see us, trust me. Next sheet should be in your pile, it looks like this, you're like, what the heck is this? So this is our behavior log, it's just an example of what it looks like. I don't know if they use it on assisted living side particularly, they may not. But you never know if you might come play with us, so just in case. If you have a resident that's having behaviors, refusing to eat is not a behavior. But maybe my nice, gentle mom all of a sudden swinging on people, that's a behavior. That is something we want to track. And we look to you guys for that because you're in that every day with them, okay? So each resident at each nursing station, and we have 3 over there, has in the book, and it says behaviors, it's literally just a bunch of these papers by date. What we want you to do is write, what is that behavior, but please write also, what did you do? I just left them and hope they got better. No, what did we do? So did we redirect them and go get them coffee? Did we go one-on-one with them? nursing come sit with them, whatever it is, that way we can keep good documentation, okay? That's pretty much it on behaviors. I just wanna make sure you knew what that was and how to get to that. This sheet, the next one is POC charting. This isn't something I'm gonna go over word for you, it's just a reference. So we use point click care. Is anybody familiar with that system, or POC?
I think so.
Yes, yes,
For charting like limited.
yes.
Yeah.
When you get on the floor, you'll get a lot more. If we need to do one-on-one, we can, but it's pretty user friendly. It's like click bathroom. It's very user friendly. So right, I don't feel like I gotta do too much with it. Everybody's very helpful, but this is kind of nice. Maybe just the first few times, it's just a little reference. Stephanie did this up, and I've thrown it in orientation because I just think it could be useful for you on the floor. So that's all for you. Next, are we ready for the fun stuff? Next, I have a bunch of policies. At the end, you're gonna sign that, yes, I did indeed offer these to you. I'm not going word for word. It's just policies that regulatory you need to see. And again, you're gonna sign that you did. So, do you have the pile in there? Everybody, I just wanna make sure. So, bathing a resident. Again, I'm not going word for word. What I want you to know on bathing a resident is typically, and I don't know on the assisted living side, I'm assuming it's a little different, but on the JP or skilled side, what we do is typically you'll mostly only have one on your shift scheduled unless there's a makeup, or maybe we're a little bit like somebody called off and we just gotta cover, but I like that because everybody gets a good shower, you know what I mean? We're not doing 2 and 3, and I know that can get hectic. It's one. We do expect that gets done unless they're refusing, and if they refuse, which they have a right to, we do a makeup shower list. That we're not just gonna not shower these people. That's not acceptable here. The other thing that is right behind it, and again, this is more just reference, on shower day, your nurse will have these out for you if it's your shower. We need you to help us with that skin check. You are supposed to come get the nurse once they're available to view. Sometimes that doesn't always happen, but if you definitely are seeing something brand new, like, oh, I got John Smith on there, and Vaughn, you really need to see the skin tear. I didn't see this last week. We need you to let us know, and maybe not Vaughn, but the nurse on duty. You also need to mark it on the sheet. So also maybe John Smith has this bruise that's been there for 42 weeks. It better be on the skin sheet every time. I want you to repeat that even though you saw it last week. Does that make sense? And there is some documentation, your signature, making sure you did the nail care, facial hair, mouth care. Mouth care is huge, and we're gonna get into that, but I wanna make sure that you guys are, it's a big deal because what we have found in the medical community is that sepsis, which is very deadly, it's the #1 cause of death worldwide, even over COVID. A lot of times what they find is the infection and the bacteria that they find in the bloodstream that cause that blood infection is the same bacteria that we carry in our mouths. We also did notice in a study that was really cool, that I was actually at the hospital that did the study, is our vented patients, or if they had like intubated on the machine, we did oral care religiously every 2 hours, and we prevented our vent associated pneumonias dramatically. Oral care is huge. Please don't skip it. If you can't get to it, I have no problem going and scrubbing them out. We have like Bree, for example, one of our CNAs, she was light duty one day, and I said, let's go do some good oral care all around. So we do find those things very important, and that's why we like to kind of just one shower, one person focus, get them clean, okay? Plus, I think about it this way, if you're only showering once a week, once you want somebody kind of scrubby-dub a little bit and help you out, so just think about that.
Good question.
Yeah.
So, are we going to be carrying around like these each day? Are there going to be like cases like this, just like?
No, so this is all just our orientation showing you, but like, let's say day 1, or even when you train, it's shower day, you're gonna see a sheet like this with that resident's name on it. So once you're done doing it, you'll come back and do that part.
Okay.
That like, yeah, I did it, and they'll show you a little bit of that. Or if you didn't do it, don't say you did it. That's fine. I mean, like, I'd rather you say no, they didn't want nail care than say, yep, did it. So.
Do the residents shower or in their room, or is there like a bathroom?
Depends. So when we're done, I want to give you guys just a quick another walk around tour and show you a few things like the shower room and stuff. I think we have a really nice one. So some residents use that, but no, they don't have showers in their room. I'm lying.
No, the rehab rooms that's not open to.
So I'll show you what we mean. We kind of shut down during COVID and brought all our population together, but we actually have dedicated rehab rooms that, yes, they have their own showers. Otherwise, I guess it is community, the one, yeah. Thank you. Good, any other questions? Assisted living side is a little different. I forget you guys are assisted living. It's new for me to have assisted living with me, so bear with me. They do have their own showers. They have private rooms.
Okay.
I forgot about that part.
And they got community ones too.
Do they?
Like, yeah.
If they need it, okay. And like, they are gonna be a little more independent, but it doesn't mean you're not gonna be helping with things, right? Next is fall management program. So we went through a lot. You may not have even realized it, but some of those preventative measures for dementia, the ADL stuff that we went through, all of that is to prevent falls. We do not want falls here, not because, oh gosh, the state, they will get hurt, okay? I came from the ER environment and I don't know how many broken hips, head bleeds, things I've seen that were so sad from just a fall. So we want to do everything we can to prevent that. And you guys know that, I understand that, but we go above and beyond. We just really want to make sure. We have a couple that make me nervous, but we group watch them constantly. Is he up? You know what I mean? All of us. So that's how we get through that, but falls do happen. Our DON, Jenna, during her end of her master's program, put together a really good fall program on our skilled side. I don't want to get into the meat and potatoes too much because it's one of those things until you do it, the paperwork's kind of not going to make sense. I can show you the paperwork when we hit the floor. I like to show you the binder. CNAs do have a part in it. I don't know if assisted living, it's going to be a little different, but again, if you come to play with us on the skilled side, if there, heaven forbid, is a fall, we'll grab that packet, the nurse will initiate it, but there is like the CNA statement. Did you see it? What was going on? When was the last time you checked on them? And it's not retaliatory, it's how can we prevent this next time? How can we make this better? If you consistently just ignore the things that are in place, then yes, you are at fault for that fall. However, if you're following protocol, you're doing the right things and the fall happens, we try to prevent it, but that's just the nature of what we're doing. So with that all being said, just preventative measures. You're drinking your coffee because you got a little second, that's fine, but maybe just help watch out, man. We're watching out for all of our residents together.
Do you guys use tab alarms?
Do what?
Tab alarms?
No, we do not. Nope.
No alarms.
I'll get to that in a minute.
Okay,
We have
so-
wander guards,
Okay.
but no fall alarms. We have
Gotcha.
little tricks that we can do, like put the, call light maybe to the side that when they go to move it goes off, but no, we're not gonna do fall alarms.
Okay.
I feel like it's more of a dignity thing, at the
Yes,
end of the day.
some places I've been to didn't allow that.
Yep, nope, we don't have them. And our call light system's silent too. It
That's
actually,
so nice.
it's not the most functional right now. It's supposed to go to ASCOMs and we're working on a brand new system, but we watch the lights. We are on them. This is, I love this
I
place.
bet the residents like that though.
They do.
I bet they're quiet because some places
Oh,
are,
that
what
is-
is that beeping?
And it can actually cause things to happen. It
Yeah.
can distract
The lights is
people.
outside their doors, right? So you guys don't use walkies or pagers?
We have the ASCOM phones, but they're not that functional, so we're waiting to transition to this new system. It's coming.
Okay.
In the meantime, yes, we are watching. I will answer a light, even if I can't, I'm on limitations, but I'll still you need to go to the bathroom, I'm gonna leave your light on, let me go find someone. And I go find someone, I don't just say that, we're not gonna do that here. So, yes, we're on top of those call lights because why? Falls, right? If somebody is self-transferring when they're not supposed to, we are very all hyper aware of that and we are hyper watching them. Because again, can cause issues.
Do you guys do where there's a fall risk that one person, or if somebody had too many incidents, they become a fall risk and you're like, okay, you have to.
Yeah, so part of that fall program is we always initiate something immediately. So if a fall happens at 2 a.m., you're not gonna go care plan and put orders in, you know what I mean? But what you're gonna say is for tonight, we're gonna either maybe get them up out of bed and sit with us, or, the nurse will help with those interventions. And the CNAs, they need 2 signatures from the CNAs that we're all in together on this plan. So yeah, we do, and then we do a falls meeting weekly at the leadership level. Actually today we just did it, and we talk about these people for 6 months after they fall. And if they fall again, it extends it. So we are very, very much on top of this, and we love ideas. So if you're like, hey, this person that kept falling, what I noticed was they always fall at 3 a.m. and they're calling out for coffee. So why don't we just have their coffee ready? We will care plan stuff like that, so please bring it to us. You're my eyes and ears, okay? Now on the assisted living side, I know, and we do a fall assessment in the nursing level when they do admissions. You know, so we kind of know what their level is and do communicate that. And I'm sure it's the same on the assisted living. It's just gonna look a little different because they're more independent. And honestly, to me, that means the fall risk is higher. So keep alert. Yeah. You don't want nothing to happen, and you're gonna love your friends when you meet them, and you would be devastated if something happened. So we just do our best so that we can sleep well at night, and so can they, right? Oral care, I think we've gotten into that. As far as the skill side of it, maybe some of it you haven't hands-on done. Just even if you're off orientation and this comes up, like, oh my gosh, I've never cleaned dentures, and this is the first time. Don't be afraid to ask someone, okay? And I'm not gonna lie, sometimes a Google video is helpful. It's like, oh, okay, I kind of get the general idea of that, right? Just make sure, the big thing too with oral care is if somebody's completely dependent, you definitely don't want them laying flat when you try to oral care. So that makes sense, right? You want them upright. One thing that we did just initiate on my side is called the Fraser Water Protocol. Has anybody ever heard of that? So I won't go too deep in the waters with it, but just generally speaking, it's for somebody that typically is on like nectar thick liquids. It gives them a chance to have some pleasure drinking. Nope.
Okay.
So what we do is, it's very precise. It has to be around meal times a certain, like they cannot eat. They have to have not ate like 30 minutes before. Don't quote me. There's a protocol, but I just generalize. And what it is because we want to prevent aspiration pneumonia, right? That's why we do these things. But what we can do is give them just water, good oral care, because I just explained why. We give them fresh water, and we do that because in that moment, if they were to start coughing and aspirate, our body is made of water. It's not going to cause a problem. The problem comes when there's bacteria in it. So that's why the oral care is important. There's a lot of things to get to that point. I only have one resident that actually meets the criteria, and she's so thankful and so happy. It gives her a chance to drink normal water, okay? Skin integrity, skin tears. Big problem, obviously, in the population. One thing that we have going on, you know, they may have jerry sleeves if they're real frail. If they are care planned for those jerry sleeves, I better see them on, because that is a protective thing. And you guys have probably seen it where it's just paper thin skin. It doesn't take much. But to us, it may be, oh man, I got a skin tear. But if that gets infected and they're real frail already, like, you don't want to do that. We're trying to, you know, give them comfort, make sure they're happy and healthy the best that we can. Skin tears do happen. We try to prevent them. If it does happen, you do need to report it so that we can follow up on it. Again, it's not, you know, we're not coming at you. We're not going to come after you. But we may come and say, did they have their jerry sleeves on? And if the truth is they didn't, be honest about it and be like, please don't ever do that again. Now you've learned, hopefully you don't ever do that, because they should be on. For example, today though, however, we had somebody that was on them and he's lost some weight and they were a little too big and he actually got a skin tear. So our correction was like, let's get the right ones on there. Another thing we've instituted is a nice bath blanket protocol. I shouldn't call it protocol, but basically, if somebody has that frail skin and you're doing the lift, give them a little extra, just a bath blanket tucked in real quick, just while you're doing the lift. It's just an extra layer of protection. I've got a few that I'm picturing in my mind that I am so afraid that I'm just gonna rip their skin open just from touching them. So, I mean, I actually had one that skin teared just from lifting her shirt up. So we definitely want to be careful with those. We're monitoring for those at all times. You guys are usually the ones that catch them before we do. So please let us know so that we can take care of them. They do happen. It's not that you did anything wrong. As long as you're, again, following what we're telling you in the policies, you should be good, okay? Any questions on these? Okay. Anything you want to add, because you're my one friend?
No, you just mentioned the bath one
Yep.
too, so.
Okay.
Yeah, just making sure if you have someone that's in bed often, making sure you rotating and reposition them every 2 hours is very, very important.
That too, yep. Prevention. We're all about prevention. So you will see we're up and down with our residents, but that is very important for them and the range of motion and getting on those positions, and it will help prevent skin issues, which fall skin issues, two big issues, right, in this population. Next is vital signs. You guys are probably all at least somewhat familiar with how to take vital signs. We have all the equipment. Please don't ever think that you can't ask for something if you need a blood pressure cuff, or we use nurse on a stick, as I call them, the little, but we have the manual equipment. Every day right now during the COVID, we have to do full set of vitals and a COVID screen. So I always worry I'm gonna say it wrong on the skilled side, and they probably do on the assisted living side. I'm assuming something similar, vital signs. Sorry, I don't wanna mislead you, I'm still learning, but they will show you.
They should.
On the skilled side though, it's like days we'll do odd or even, and then it flips at nights. That way you're only kind of doing one set.
And
Bath,
And
shower
not a
days.
full set, just pulse, temperature, respiration, and oxygen. No blood pressure needed.
Okay,
Just FYI.
gotcha. Good point. However, shower day, full set of vitals.
Yes.
Full set of vitals. Right now, Jackie, who again is our restorative aide, is mostly doing our weights. So right now, you guys don't necessarily have to worry too much about that, but don't take it off your plate. If it needs to be done, we are gonna come to you for it, okay? I'll show you the scales. I think they're really awesome. They're the wheelchair ones. We have 2 in the facility, so it's pretty painless to get these weights. So, do they do weights on shower days for everybody, or is it just if needed?
Just Jackie.
Just
So she have her days unless it's the daily weight, and if the weekend, then you'll be assigned.
That's true. If it's on the weekend and it's a daily weight, then you guys, it'll come up in the POC.
Yes, it should come up.
There you go. Any questions on that? Elopements and wandering. We don't want our friends to leave us. We like them to hang out with us. So, we get a few that wander aimlessly. They're not really purposefully trying to get out. Maybe one that every once in a great while gets in a mood and she's trying to get out, but she doesn't have the ability to really try to get out. She's just trying to get out. With that being said, we do have the Wander Guard system. Are you guys familiar with that at all? Seen it at all?
Mhm.
No, that's okay.
The
Are you-
bracelets.
Yes.
Where it beeps on if they
Or
get
the-
Yep, so it's a little
Yeah.
bracelet and it should be on the person unless absolutely cannot, because wheelchair could be separated from person. It should be on that person, and there's times that maybe they can't, but that is the goal. That way it's the safest. It will alarm when they get close enough to the doors. We have to shut those alarms off with a code. Do not shut that alarm off if you don't know for sure nobody got out. Sometimes maintenance will open our back door, it'll make the alarm go off, but please make sure that we don't have a missing resident before you shut that alarm off. I only have a few people right now on them, it's not that often. Doing okay? Okay. And we all look out for the residents. The activities is really good about getting them up front, but there's times they start wandering. You might have one from way back here that's all the way down by my office, but I will gladly bring them back. It's a team effort. We keep them safe, okay? And once you get on the floor, we'll show you the codes. We'll show you kind of where it's going to alarm, okay? Any questions on that?
The only thing
Go
is,
ahead.
if they're wheelchair bound, it will be on the wheelchair.
Thank
If
you for
they're
that
not able
correction.
to, like, get up and walk,
I didn't realize that. So
If they
ambulatory
feel the want-
person,
yes,
wheelchair.
yes, yep.
Thank you. I didn't know that. That is it for policies and procedures. Any questions on those? You want to sit and read them word for word first? I'm just kidding. No, you don't have to carry those with you. All of that is all for your reference. I do need this signature if you didn't already, which it looks like everybody did. Guys, that's day 2. I do want to take you on the unit. I want to show you a few things real quick. I do need to go back and do a couple of things with you guys, but let's get off, walk a little bit, and then we'll wrap up with you two. Sound fair? No, because we're not all swabbing right now, so I'm not gonna make you swab. Remember, we kind of talked about that, but as long as in general, usually we'll let you know again if you're on that swab list. Trust me, we will come find you if you haven't swabbed. Okay?
Yes.
I'm trying to think if there's anything else. I think that's it for this. So,